So first of all, I did not choose this title. Where's Sharon? Sharon chose this title. But I knew, yes, ma'am, I will give this talk. And I've counted at least 7 neurologists in the audience, which is more than many states in the United States have. So there's a lot of experience here. And I bet a lot of the parents and family members have a lot of experience about a lot of things I'm going to talk about too. So I'm going to give you a broad overview of epilepsy. I'll tell you along the way as AHC-centric as possible. So you heard multiple times already, we don't know a lot, the details about it. And epilepsy is something that almost 100%, I think, 90% of the times comes up as a misdiagnosis initially. And it's cruel because, well, your child doesn't have epilepsy, they have this. And then later you can have the seizures too. So it's something you need to grapple with. But I want to give you, again, a big picture walkthrough of how epileptologists approach children and then how we treat. I'll share with you, I was clear from the title that Sharon wanted me to talk about some side effect issues. And there's just definitely options you can have. And to be complete, I'll include other options of treatment, including dietary therapies, alternative therapies, and even some surgical therapies too. And I don't mind being interrupted, but for the purpose of the webcasting, it might be to just wait to the end, but either way is fine with me. Okay, and then my disclosure is I participate in a clinical trial for this drug called Vimpat. There are 2 patients left on the study, and they're going to be done with the study next month, so I can take my disclosure away. I'm going to mention this drug later, but you'll see I have no particular emphasis on it. We're just trying to look at its efficacy in children with one type of seizure type, but that's my only real disclosure. Otherwise, that's funding, as you see here. So I'll talk to you about some basic definitions, which I find many, many people, whether you're parent, patient, student, physician, who should know better, often use different words. So we'll define our terms a little bit as it will. Talk about some different types and think the differential diagnosis. What could be other than a seizure? Because it's often not seizure in AHC. I'll talk about some different medications, the newer ones, which are always better. I don't know why people think that, but they're newer. And I mentioned diet as well, other surgical therapies too. All right, so billions of neurons, literally trillions of connections. How could it ever go right? And it doesn't. No one's ever here, I think, is normal, including myself. And things happen, and often in any neurologic condition, when the brain doesn't have appropriate connections, seizures is a very common pathway. So we're thinking more now of a research side. You're having seizures because the brain cells are going fire, fire, fire too much, or they're not saying don't fire, don't fire. So the analogy always is imbalance between the gas of the car and the brake of the car. If you lose your brakes, you're going to crash. If the gas is stuck down, you're going to crash. And drugs really work on both of those sides of the equation. And then this reminder of that we're talking about the cortex here. There's reasonable to think AHC involves subcortical areas below the surface of the brain. But seizures, for the most part, are a cortical gray matter phenomenon, this layer at the top of the brain. So it's definition. I like this one. A seizure really can be simply thought of as the electrical event that leads to some sort of measurable, something clinical you can tell. There's many, these are the simple rules, many exceptions, but this is a very helpful diagnosis. And the electrical discharge allows me to introduce the idea that we do use EEG a lot, electroencephalograms, and this is a very helpful tool for epilepsy in general. And then epilepsy really means 2 or more seizures unprovoked. So if I had car accident on my way home today and I had seizures from that, I had traumatic brain injury that caused the seizure. That's really not epilepsy. Epilepsy, again, is more of a condition of recurrent seizures. You can't clearly point to something that's going to be the problem. And there really is an operational definition. So if we say your child has epilepsy, it means they've had repeated seizures, and they're probably going to have more, and you probably should be on something to prevent you from having more. So it's really a functional definition. That's why it's usually 2 or more. You often get a pass if you have a single seizure, and maybe we can talk about AHC being different since the rate of epilepsy is pretty high. And I should just pause to mention that in general, our best evidence, which is not great, but our best evidence from multiple studies is we usually use the word about 50% of children with AHC will have epilepsy at some point. 43%, 70%, something like that. So 1 in 2 chance. Not great, but there's some hope that you don't have to be that person. And then within that, I'll talk about different seizure types as well to make it more AHC-centric. And then these seizure types, though, the two big buckets we often use, and you heard doctors talking about it, are generalized or focal partial. And that really means from an EEG point of view and from what you can observe, do the seizures start from all over the brain, that's generalized, or they come from one part of the brain, that's partial or focal. And this is important because it tells us, again, a little more detail of what's going on, but also should help guide your therapies. Oh, and then there's the complex partial seizures. That's a very common type of seizure you hear. It really just means that during the seizure, you have some alteration in your awareness. And that's a very common type of seizure. And I'll show you an example, the videos work of some partial seizures. All right, I think most people know about the EEG, and on a simplistic level, you're measuring electrical activity of the brain, which is pretty cool. It's EKG is similar technology. This is 100-year-old technology now. Why it's getting more refined all the time, it's pretty established. And what everyone thinks we use EEG for is seizures. Are you having a seizure, yes or no, right now? And that's often not the case, though I'll tell you an exception to that. But the EEG is also very helpful for finding signs of seizures. Signs that part of the brain are electrically abnormal, and also patterns that may tell us whether children have normal patterns as they get older and as they develop. So we can often use EEG to tell us whether someone is developmenting appropriately already. You already know this from your child, but the EEG does have such information. I think it's more of a neurologist thing. We focus on all of these patterns and what's normal. But what most people, including families, really want to know about is there some seizure, epilepsy-related pattern. But it's a very helpful tool, pretty easy to do. That's why we want to do it often. And then this was mentioned earlier in Dr. Sanger's talk, that the epilepsy monitoring unit, where we actually admit patients to the hospital for days at a time and have chronic recordings with electrodes, is really the gold standard for determining someone who has epilepsy or not. You don't always have to, or even often have to capture a seizure in a patient to know they have seizure disorder and epilepsy, because your event that you described is very clear and the regular EEG is fine and you can treat. But if you're really not sure, and in AHC, I think this happens a lot, you actually bring them in the hospital, do some sort of prolonged recording with video camera at the same time, so you can actually look at the event and decide yes or no what's going on. And this is really the gold standard, meaning that this really should tell you the answer. It's highly sensitive and highly specific. So we do many. That I said the average admission, if you're thinking about something like this, is probably 2 or 3 days. It depends on how often people have their spells. I'm going to show you a few examples of EEGs, so you can look at the monitor and impress the next time you have one done and talk about now. But really, it's just measuring electrical activity of the brain. There's an amplifier because our brain activity is very low. For aficionados, it's microvolts, so millionth of a volt is the electrical level in our brains. And then these little numbers and letters. The code is the odd numbers are the left side of your brain, the even numbers are on the right, and then the letters just refer to where they are. F for frontal, C for central, O for occipital. So this really tells us a 3-dimensional kind of reconstruction of where electrical activity issues are. And people often, this is an aside, wonder why we do EEG, why we do MRI of the brain. And they're really very complementary. MRI is structure of the brain, picture of what things look like right now. EEG is much more a functional assay. And by doing them both together, you can get a lot of good information about whether someone's having an abnormal brain and where the seizures, if that was is, where they're coming from. So this EEG here is an example of a generalized seizure. It's all over the brain. The EEG discharges here are just all over the brain at the same time. I'll show you an example later of a focal seizure. And then this is normal brain waves here, and then these are the discharges. This is an actual seizure. And this is a pretty common type seizure people know about. This is the absence seizure, or the absence where you just have a staring spell. And then the ones we think worry about more in AHC are generalized tonic-clonic seizures, and that name is pretty good. You first get stiff, that's tonic, and then you start jerking, that's clonic. But what most people call them is the big one, the grand mal, and these are the ones that get your attention because they're scary and frankly dangerous, and you do see this in AHC. And these are not subtle, so if people have this, it's pretty clear. If you have hemiplegia, then you're worried that you missed the seizures and there's weakness, or they have a partial seizures, but unfortunately the type of seizures you see in AHC for sure are the more dramatic representation, either these tonic-clonic seizures or just a tonic stiffening seizures. I'll show an example of that. these seizures are bad enough. If they go a long time, that's status epilepticus. That's true medical emergency. People who have repeated seizures or prolonged seizures need very rapid treatment. This one you can get into trouble with having secondary brain damage and problems and even death if you seize long enough. Hopefully most places will have very aggressive care in place. If you can get to the hospital or EMS to get you very quickly, but this is a major reason why we give people medicines like the rectal Valium, diazepam, or Diastat, so families can administer this at home and stop this long seizure or at least prevent one from becoming longer. And then you go to the hospital and they make sure everything is set. Other medicines are listed there. And then this one caveat is you can have a generalized seizure, and that's pretty obvious, but many of these seizures actually start focally in one part of the brain, but then they spread. The people forget about the subtle symptoms early on. They just remember the big grand mal. This is more for us to think about whether it's focal or generalized, but at the end, it's the same process. And then you can play the first video, please. This is an example of a tonic seizure, and these are actually not good seizures. They really hurt. You can tell from the families, and but also so that, there you go, that one. So this is the guy who has intellectual disability, and he's giving his mom a hard time about the food. And he can go into very clear seizure in a second. And this is more stiff, more tonic, which is seen more often in AHC, I think. This is kind of the small series we have. You just get stuck in that position. Okay, we can move on. It's enough. And afterwards, he recovers pretty quickly. But these can be bad, especially if you're sleeping. You have this stiffening. You're kind of close off your air box a little bit, and it can be potentially quite dangerous. I should say, by the way, all the videos, two videos I'm going to show you, I used to, when I was a fellow in training, I used to collect seizure videos from my patients and get consent forms, and so I could show other people the videos. Now you just go to YouTube and download them because people put their own videos up. It's crazy. And I'm pretty sure if you have a public YouTube video of you seizing, you have given consent for everyone to watch your videos. Wait, yes, sir. During the actual seizure, he's not responsive, but he recovers pretty quickly. Again, just YouTube tonic seizures, you'll probably find him eventually. But, okay. And then skip this for now. But this is another example of a generalized seizure type. An actual tonic seizure has certain EEG patterns. But again, I don't think anyone would miss that as a seizure. That's pretty clear. So the other bucket, again, of seizure types, again, is either same thing, focal or partial seizures. One focal part of the brain is starting to seizures. And these are quite common. I'll show you an example video of a simple partial seizure. And again, the complex or dyscognitive is a more modern term. This means that you observe that something's going on, or you know if it's you, that I lost some time, or there was some alteration in my mental awareness. And that's generally the most common type of seizure for anyone, for anything. And then the second video, please. It's also on the side. So this child's going to have a simple partial seizure, meaning that if you were to talk to her during it, so she has an face seizure, just the right side of her face is doing this repetitive clonic type movements. But if a person was confused during this, then this would be a complex partial seizure. And these are definitely seen AHC as well, too. Okay, that's enough. Thank you. Again, YouTube. Very cute. And then this is a different EEG type than this child's seizure, but illustrates the point that on the EEG during the seizure, if you were to actually have the EEG during the seizure, you would see the electrical patterns in a very discrete area of the brain march through. And these focal seizures are definitely described in Alternating Hemiplegia of Childhood. This is an example of between seizures in a different patient where there's a little spike activity here and here on the now left odd number side of the brain. So this is an example of the EEG you see in the focal seizure. And that by itself, with the right clinical description, what did you see, what it looked like, this EEG not only tells you what type of medicines to avoid or to use. In this particular case, it tells you the actual syndrome too, with information about what type of seizures you have and when you may or may not grow out of it. So the EEG, again, is very helpful. I would definitely use it a lot. Okay, but seizures are bad, right? There's no such thing as a good seizure. They may not be as bad sometimes as you think, but they can be bad. And I'm going to share with you, because due diligence here, I have to share with you some of the bad parts of this, as the good and the bad and ugly, right? And they can be very dangerous to people, and you know why we think about this and what we try to do to minimize such severities. And we just know in general that if you have epilepsy from any reason, you have increased risk to dying from it, or just have increased risk to having problems in general. You can have a seizure, and you can essentially aspirate or have contents of your throat or stomachs go into your lungs to get a bad pneumonia. You can have various trauma from having the seizure. People who are more functional adults could be in car accidents. You can drown. I mean, all these, I'm sorry again, all this bad stuff can happen. And your job as caregivers and our job as providers is give you information to really minimize the likelihood of that happening. So if you just look in general, this graph shows you over 30 years, there's just every year a little excess mortality than you expect. These are not benign things. And one of the scariest things about it, which fortunately you do not see that often in kids, I've seen only a few in my career, but it happens, is this SUDEP, sudden unexplained death in epilepsy. And this is, you know, not the most perfectly defined term, but the patient has epilepsy and they die pretty unexpectedly, and there's no other associated cause of it. And we think mechanistically this could be because they did have a seizure that no one noticed, and it was severe enough, like that tonic seizure I showed you. People can definitely die if they have enough of those and they like roll over their bed and obstruct their airway. That can happen. Or we think also there's very strong connections of seizure discharges sometimes to your heart too. You can have arrhythmias of your heart and actually have a cardiac arrest. So whereas neurologists, we're thinking much more about the heart now. In AHC, we know the gene ATP1A3 product is expressed in cardiac cells as well. So there may be something more to this. But one of the reasons we treat children, people who have epilepsy, is because we think the risk of SUDEP is going to be lower if you're treated with medicine. And this is an important point because you do have situations where the seizures, oh, they're infrequent or they're short, and you might be okay, but this is a big, bad, ugly for sure, and you want to minimize as much as possible. Again, this is more of the young adult manifestation. Since my practice is in pediatric, I don't see quite as much of it, but this is something we worry about. Okay. So what else could it be? And we have non-judgmental terms when we admit patients. We're not sure what they have, and we use the word spell. And I always think of, you know, Harry Potter. It's a spell. That would be cool. I wish in Harry Potter they could just like cure disease. That would be great too. But there's different things near and dear to all of our hearts. Hemiplegia and migraine are well-known mimickers of forms of epilepsy. Various movement disorders we heard very ably this morning. There's non-epileptic seizure spells, otherwise known as pseudo-seizures, which is more of a psychiatric manifestations. I don't think we see that often in this group. And breath-holding spells is something that's pretty classic in young children, which could be thought of as epilepsy, but in the setting of AHC, of course, I think we're mainly worried about, is it hemiplegic episode related to a migraine, related to AHC, et cetera. But again, with the complexity that we know the patients, while this is usually the misdiagnosis early on, is still a diagnosis potentially later. So I mentioned already why you treat. Seizures are not good. Seizures disrupt your life. They disrupt learning. They can be painful. They can be embarrassing if you have incontinence or issues. Well, for all these reasons, we prefer 0 seizures. I mentioned the SUDEP. And while since it's rare, it's hard to know how much you decrease SUDEP if you treat, but we definitely think that's one thing you should be aware of. Now in 2016, there's many drugs, so many choices for children. Some of them are FDA approved and some of them are not. And while we like things to be FDA approved for what we do, if we waited for that, we wouldn't treat anyone in pediatrics. So there's a lot of choices. I'm going to walk you for the next 10 minutes or so through a list of a lot of the drugs. And this is my very personal experience, but it's backed up by data and a lot of experience of what the common side effects are. Because every drug, like everything in life, needs to be risk-benefit. You need to know the side effect profile. And when you're starting on new medicine, you ask that question, you know, what are the side effects? You should get this information, but I'm just going to laid out for you because I think it's helpful. And I mentioned this here, but if you're going to pick the right drug for the right seizure type, the right syndrome, the issues, the tolerability, the side effects, all the other things going on. So you don't just pick a drug and use it. All right, so we do use the first one a lot because it seems like it's very effective, Keppra. Also, levetiracetam is the real name for it. And Keppra, almost all the drugs now, by the way, now are all generic, which used to mean they're cheap. But now it means they're probably not as expensive, but they're still expensive. But Keppra is used a lot as the first drug because it treats both generalized seizures and partial seizures. It does have side effects, but it's pretty minimal side effects. Again, the terminology here is me being a little dramatic, may make the child crazy. So it will make children often irritable, a little more aggressive, and that can be a big problem. So most kids actually do not have the side effect. But if you had to pick one thing, and pretty much this is it, Keppra will cause behavioral exacerbations. And it's pretty significant when it's bad. It's totally reversible. Yes, 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 it is. Yeah, that happened. Yeah, but it went away, right? You stopped it? Good. And as long as talking about that, we have some things that are not well studied but easy to do. Vitamin B6 pyridoxine is an over-the-counter vitamin. A lot of patients find, I don't know if you tried this, vitamin B6 will help blunt Keppra's aggressive irritability. So it's worth trying because Keppra is a very good seizure drug. And if you can get it to work and you don't have the behavioral issues, you're in pretty good shape. Yeah, sorry. Yeah. It's usually not that dramatic, but I believe you. Okay. The next one is really the tried and true medication for partial seizures, oxcarbazepine or trileptal. This is the newer cousin, though it's still old enough that's a generic, of Tegretol, which is carbamazepine. And it's good for partial seizures. And actually, it's bad for generalized seizures. So this is actually, you need to be thinking about your epilepsy diagnoses. Because if you give this drug to people for the wrong syndrome, sometimes it can make those seizures worse. So you have to pay attention. You have to get the EEG and think about it. And trileptal is the brand name. I have right here, sorry, carbamazepine. And they're really both about the same. There's a little different chemical structure, but they have the same idea, these carbamazepines. Zonisamide is actually a very good drug that I think is a little bit underutilized because it's pretty broad spectrum, again, partial or generalized seizures. It can be often given once a day because its half-life is quite long. That's compliant. So if you have to give something to you or your children once a day versus twice a day versus 3 times a day, we know compliance drops off for everyone just because life comes at you. So if we can do once a day med, that's usually better for getting the med in. And a lot of these drugs, I'm not going to mention because it's more pharmaceutical things, they're making once a day version of all these drugs. And the cynical part of me says they do that so they can have a new trademark drug and then they can charge you more. And that's true, but also the benefit is if it's once a day, you're more likely going to get it in people consistently, and that's actually worth it. But sometimes you have to fight insurance to get that to work. Topamax or topiramate, I have a love-hate relationship with. It's a very good seizure drug for a lot of different seizure types. It has side effects that I really don't like for kids with intellectual disabilities. This is more at higher doses, and I know people use this drug for kids with AHC, but it will definitely cause cognitive issues. Hard to talk, and it's already a challenge for many kids. Hard to think straight. So again, this blunt language to drive my points home. I prescribe this a lot for patients with epilepsy because it works well, but you really have to know about the cognitive side effects. The other major side effect is this one, weight loss. So you can definitely drop the weight. And I had someone say earlier, my kid does used to 106 pounds, I remember that. Yeah, so that's Topamax, you know that, right? That's the side effects of that drug. Yeah, so it really inhibits your weight gain. In fact, the company, this little fun aside, the company that makes this drug approached the FDA for approval to use this as a weight loss agent. And FDA said no, though if you ask people, would you like to be skinny and stupid? And they said, yes, I would. And to this day, you can still see, if you ever drive by and there's big billboards and it says medical weight loss clinic. Have you seen these? Like physician weight loss, whatever. They give you Topamax because off-label, it's very effective to lose weight. Anyway, that's just one of the side effects. Do with it what you will. Ethosuximide or Zerontin is an old drug, and it really has now one purpose, and you may not unlikely see as much in the AHC population. I could see it as a second agent. It's really just for the staring spells, the so-called absence seizures. And I think that's really a different syndrome than what you see in AHC, but it's just something to know about. You don't use this one at all for the partial seizures or for the grand mal seizures, so you probably won't see this. These are still considered to be old drugs, by the way, because they're all generic now. Lamictal or lamotrigine, it's actually a really good drug in the sense that it has pretty minimal side effects. People take it a long time and don't seem to have any issues with it. Really, the only thing you say about it is the rash. So there's a condition that's bad called Stevens-Johnson syndrome, which is basically a burn-like condition. We have such a bad rash. You should know that we didn't know about that condition when Lamictal was first used, and it was such a good seizure drug that everyone got put on it, and then people were caught unawares about the rash. The modern era, the last 20+ years, everyone is so worried about the rash, and they should tell you the rash. That as soon as you see the start of a rash, we stop the drug or back off and think about it. And there's been zero really Stevens-Johnson syndrome since you have that awareness. So one of the examples where the old drugs, because they're old, why are they even good old drugs? But we know all the problems with them. Whereas the newer drugs, you may not know about the rarer side effects until you treat 100,000 people with them. But other than the rash, which really is not an issue, because we start at a low dose and go slow. So that's really the downside of this drug. If you want to use it, it takes you several weeks to months to build it up to a good level. But once you get there, the risk of a rash is pretty low after the 6 months time. And moving forward, you're good. So it's a pretty good choice for a lot of people. Now, Depakote, people don't like Depakote. It has a bad rap because we know all the side effects. And there's a long list of side effects. But for the right patients, particularly boys, because there's some ovarian issues that you worry about with girls, it's actually very effective for different seizure types. And it's one of those older drugs which is now making kind of a comeback. So again, I tell people I know all the problems with it. I know what I have to do. The one downside Depakote along those ways, we have to take, check blood chemistry and CBCs and levels, things like that. I usually take them twice a year, not too bad, but there's still blood sticks, which is something that all the previous drugs I mentioned we do not do. So that's one of the problems with it. So here's some newer medications. Newer meaning they've been out with FDA approval for epilepsy for at least now 3 to 7 years. They're still under patent protection, so they should be expensive because of how they are. Rufinamide, also known as Banville, it's not quite clear how it works. There are drugs we have a better idea how they work, but we think it works as a sodium channel inactivator. We discussed sodium channels earlier, Dr. George. And no really major side effects. This is what it looks like chemically. And there's another drug that I mentioned that I have a conflict for them on this trial, but it's lacosamide, also known as Vimpat. It's probably a similar mechanism of action, and it has actually pretty similar chemical structures, kind of makes sense. We've been using this now, both these drugs, with many children, and the way this usually works, you start off treating people with the worst types of epilepsy, and then you move on to less concerned type of epilepsy. And they seem well tolerated, I'd say, for both of them as a group. And we have not yet seen any major side effects, problems I'm aware of. And that should be the case, because if you're really going to compete in the marketplace against now a dozen or so older drugs we have, the newer drugs really should not cause any major problems. But I'd still be cautious if someone tells you, put your child on one of these newer drugs. We just don't have the decades and millions of years of life experience with them. But they're out there. A very new one is called Perampanel or Fycompa. And this is actually a very different mechanism of action. It helps block some of the glutamate channels. And the glutamate channels are kind of the go cells, fire, fire, fire. And it's shown here in a little schematic of how this drug can block these particular receptors called AMPA receptors. There's a lot of aggression concern for this drug, and it actually has a black box warning. I've never seen anyone kill anyone about Fycompa, but in the clinical trials, people apparently got very aggressive. So I would, maybe not use this one for a while, but it's a newer drug out there, and it's approved for focal type seizures. And this is actually an old drug. It's an old drug. It's now a new drug. Clobazam is in the same family as the Valium, the Ativan, the Klonopin, but chemically it's a little bit different. And when I was in my training, we used to do the, the flunarizine two-step for this drug too. We get it from Canada and bring it in because it wasn't there. And it was cheap from Canada. It was one of the cheaper Canadian drugs, which was good. And now it became FDA approved under the name of ANFI. It's actually a very good seizure drug. And unlike the other drugs I mentioned, the Ativan and the Valiums, things like this drug tends to be a good long-term drug. The other ones, they tend to not work as well after time, but this one actually works pretty well long time. And we have some sedation with it because it's in that same family. And this has basically the opposite effect mechanism as this other one I mentioned. Now this works on the brake system, the GABA I mentioned. So this actually now will help augment the brakes of the car, if you will. And so if you're going to have different drugs, you want to think about how they work, at least your doctor should, and make sure you're not doing two drugs, let's say, that do the same thing. You want to have drug A do this approach and drug B do maybe that approach. That seems to make a little more sense. So that's ONFI. And now that it's FDA approved, you know, it costs like just a ton more, right? So this is progress. But it's much easier to get. But it's a little disappointing to me that the former cheap Canadian drugs that were not FDA approved now are very expensive. You know, I'll stop. Okay, so these are the older drugs, which we still use, but I think you have to have a pretty compelling reason, given what we know about side effects and issues or just drug interactions. One of the concerns about seizure drugs in general, if you have bad epilepsy, you have to be on more than one medication, so you worry about interactions with food and things like this. So phenobarbital was one of the first seizure drugs developed, I think, in the 1920s. Phenytoin came later. I mentioned carbamazepine. And then a couple ones that are rarely used, I'm trying to be complete, are phelbutol and tiagabine. And they have their use, but they're really reserved not only for neurologists, but for epilepsy specialists who do this day in, day out. And people who are on these drugs usually have failed multiple other drugs. And because they have significant side effects or very restrictive uses. But there's still a role for them. All right, any questions about drugs? I guess I can stop right there. Yes, sir. Why don't you get a microphone? We're going to switch topics here.
My kid had a seizure December 28th, and the doctor gave him Keppra, which I had as him being allergic to, at the ER. I was in California. He was home at a care facility. And I don't know why, first of all, he went and gave him a medicine that it said he was allergic to. But the other thing is, why would Keppra have been used as something for like an emergency stop on a seizure instead of something like you just had phenobarbital, which I thought would have been more logical.
Okay.
Item.
I can't speak to your specific medical issues, but if something's listed as allergy, you should not give it. Though in this case, he doesn't have an allergy. He has an adverse reaction. He gets aggressive, right?
Yeah.
So he still shouldn't have gotten it, but it should not be listed as allergy in his medical record. Allergy is rash, hives. I mean, it's really different. But either way, you're right. They should have not given it. And there is a life of Keppra and other drugs as acute treatments, usually of status epilepticus.
Oh,
but
it is an acute
It is,
thing.
but most medical centers, at least in this country, would start off with Ativan, Valium. Short term, stop it now, and then you can do it. But if that fails, our second line drug is actually to give a load of Keppra too, and does seem to be effective in that.
Well, they didn't have any neurologists. It was
and that's probably
a doctor, and they just
did that. They probably just use what they're comfortable with. Yeah, but there's a lot of variability. Okay. Are there burning questions? Yes, sir. Microphone.
And respiratory compromise that happens with these drugs. Actually, we had been under the impression that our daughter has seizures rarely, and when they happen, they are huge, and they're never stopped by anything other than just loading her up with whatever it is that they're loading her up with. I was under the impression that the diastat is only given is given in a relative small amount because there was concern about that you really don't want to give this medication unless you're in a medical situation. But you seem to contradict that.
A little bit. So there's very good clinical data from the trials for rectal Valium that very, very rarely they have any respiratory compromise from the Valium. And it's a large enough dose. It is a significant dose, but it's not huge. The risk of having serious concerns, neurologic problems, death from continued seizures, I think greatly outweighs the relative risk of the Valium. Most patients, though, I tell my patients, if you have to give the diastat, that is the same as putting up my 911 flag. So you're injecting that, you're calling for help in that order, but it's really because the alternative is potentially much worse. But again, in the clinical trials with hundreds of patients, very rare to have actually breathing compromise. If you give enough of it, will it do it? You bet. But it's pretty rare in real world practice. Question in the back? And we'll move on.
So if we give her the rectal dissect, we're really new to it, should she go to the hospital every time?
No, but it really depends on all the circumstances, which is hard to know about. So if you're ever worried or scared, yes, you call for help. That's always right. If unfortunately you could be in a situation where, yeah, seen this, done that, know the drill, the ER is not going to do much as long as the patient is stable, and they'll probably say call your neurologist or they'll call for you. But I can't tell you not to go. Yeah. But most of my patients don't go to the ER for every time they give diastat. Okay. But it should be recognized, and if you're at that point, you're putting that flag up or at least thinking about it. You should at least be calling the neurologist on call line and seeking advice. And if you're having to give diastat repeatedly, something's not right in your treatment plan anyway, and something else needs to change. Perfect. Diastat should be used never, ideally. That's the goal, right? Okay. So I want to talk about diet therapies. I think I'm talking a little bit too much, so I'm going to pick it up just a little bit. This was a recognized treatment for hundreds, thousands of years maybe. It's hard to know. Not many good journals a few thousand years ago. But it was a way of changing your dietary intake. This is before seizure drugs were invented. And people found out kind of the hard way that if you didn't eat, you fasted, you went into a state called ketosis. And we all know ketosis. If you've been sick or had the flu and didn't eat for a while and you feel terrible, you're actually ketotic. You get a little acidic, and you make these things called ketone bodies. People found that people who had epilepsy tend to have better seizure control when they were sick. So this became then studied and 100+ years ago, and this ketogenic diet was used, and it kind of gotten forgotten when all these miraculous seizure drugs were invented. But then about 30 years ago, it started making a comeback, and a group at Johns Hopkins did the most of this work initially, but now this is a very standard thing. So some people think because it's a natural thing. It's not natural. A ketogenic diet is eating like 70% fat, a little carb, a little protein. But it does have its place, especially for younger children who have tough control epilepsy. And then the other part of it is there's light versions of the ketogenic diet, which are listed here, which is Atkins and South Beach diet. Those are all these low-carb diets have been now shown to be reasonably effective, especially for older kids and teenagers and adults. And it's much easier to keep yourself on a low-carb diet than a ketogenic diet. But they're really the same principle. How do they work? We're not sure, but we're used to that. There are some ideas in a research point of view. But if you can use a diet therapy for epilepsy, the goal would be to have better seizure control with less need for medications, better quality of life. And even if you can only do that for a few years, because everyone ultimately starts to refuse to eat it, it's kind of nasty texture, that can be huge in a child's life in terms of overall control and minimize multiple medications. So the diet is something important to know about. I haven't seen as many kids on it. So this example of a typical breakfast. At first it sounds great. Oh, eggs and bacon, yeah. And I was a medical student. I saw my first patient in the hospital on a ketogenic diet, and his breakfast consisted, I'll never forget it, of just a few pieces of bacon, just loaded up with butter. It's like eating a stick of butter with each. I mean, that's a little hard after a while. And we actually crave carbs. So in the Western diet, which is carb heavy in general, it's hard to do. So if you're motivated or a kid has a G-tube, which sometimes is the case, you can get it done. But this is a challenge often for the family as much as the child. Okay. All right, so we talked a little bit about alternative therapies. Dr. Sweeney, I don't think he's here right now, but he covered marijuana pretty well. I think we need to laugh occasionally too, so I'll show you a good cartoon I found the other day. So, Seizure Man, do you need some help? Just call me, man. I've been using medical marijuana to treat my seizures. That's interesting. So why are you on the floor? I'm so high. So that's not what we do. We use CBD, which doesn't get you high. This is THC, but it's funny. Come on. So I do think, that, and I don't want to bog down discussion, I threw out my 2 cents yesterday, but I do think CBD is going to have its place in our toolbox, which will be good because we need all tools we can. I think it's overhyped, but there will be a place for it, and I would predict firmly that it will become an FDA-approved product and it will be very expensive. That's my only prediction. Am I right? Oh, it's humongous, yeah. Sure. But you will get a higher quality pharmaceutical grade product as opposed to you're not quite sure what you're getting. And then just to be alternative therapies, I couldn't help but notice that we have out there the essential oils, and occasionally see patients who believe that the essential oils have something to do with various neurologic conditions, including epilepsy. And there's actually some research going into it, and the various oils may have some role, but usually it's like a humongous dose of the oil to show this, and I'm not sure. And to me, this is outside what's standard accepted. There's not data to support its usage. And unlike the discussion of what should we treat AHC patients with and how do we know whether it's effective, for epilepsy patients, we unfortunately have millions of patients. You can do real clinical trials with thousands of kids with a placebo or not. So you actually get pretty good data. So I would just leave it to caregivers as well as providers. If you have alternatives that you know are safe and effective, you should really probably use those before you get out into the fringes. And to me, this is part of the fringe. But the rules are completely different. We're talking about AHC because we're never going to have big clinical trials. Okay, so I would not be complete unless I mentioned some surgical options. I think it'd be very unusual for a child with AHC to have epilepsy surgery, meaning removal of one part of the brain. If we know they had a known genetic disorder, it probably doesn't make sense to take out part of the brain unless for some reason all the seizures came from one part of the brain all the time. So I'll just walk you through this workup. If you failed medical therapy, Dr. Sweeney mentioned this the other day too, we know that if you try 2 or 3 medications, you're not going to have great success with drug number 3, 4, 5. So you should really think outside the box. What else can you do? I mentioned the diet. CBD could be an alternative. But if the very focal type seizures and that part of the brain where seizures are coming from is not required for function or can be is not critical, you can possibly do a resective surgery. This is a big deal. It is brain surgery. But this is something you have to think about. So we do a lot of tests, including the EMU, again, gold standard. Where is the seizure coming from? What do they look like? What is that part of the brain doing? And you essentially can identify using MRI as well as other fancy imaging studies. And then just quickly walk you through it. If we can identify parts of the brain, these are electrodes on the brain here. Ultimately, this is resection here now, see in brown. And this is a part of the brain we don't want to take out, the primary motor cortex. So this is the part of the brain, the left hemisphere, that moves the right arm and leg. We don't want to take that out unless we have to. But in this case, it was next to it, and we could take it out very safely and effective. We don't ever want to hurt language, especially in children. So if there's a language area nearby, we're not going to do surgery on that. But sometimes you do have these options, and they can sometimes be really transformative. You can go from many seizures a day to 0 seizures or to a couple of months. So if you But the caveat here is that the patients who have epilepsy surgery are very, very carefully screened and selected. So we have a pretty high success rate, but we just exclude many people along the way because we don't think we can help them. But you need to know about surgery. More likely for surgery, you might hear about the vagal nerve stimulator, the VNS. This is, in my view, a relatively crude device. It allows electrical stimulation of a nerve in the neck called the vagus nerve, which then travels up to the brain and somehow through repeated stimulation seems to decrease the odds of seizures. It's a bit of a black box too, but the benefit of this device is, again, it's a very different approach to medications. It's not going to cause any interactions with medications, and if you have better seizure control, again, with less medicines, that's probably a plus. The downside is it's a surgery. It's not brain surgery. It's neck surgery. You have to program this device too, so it requires more little visits. But in the right setting, this can be very helpful. The other thing that people like is there's a little magnet mode. I think reclaiming control of your life is a big deal. So seizure is another example of loss of control. This magnet, you can put it over the device in your chest wall, and then you can stimulate it to fire a little faster, a little harder. So some families think that they can either prevent a seizure if they know one's coming, or take what could have been a big seizure and make it a small seizure by waving this magnet. That's not why we implant the device. We implant the device to decrease seizures in general, but this magnet mode I find is very attractive to families because, again, they want to be able to control the situation better. So something to think about. And then just the last thing about it, this little pulse generator, it's just embedded underneath the muscle in the chest here. A child 2 years and up can definitely have this done. And then the battery is housed in that pulse generator. modern battery technology lasts about 7, 8, 9 years. So once it's there, it works pretty long time. So it can be something to think about. I mentioned all these things already. And that's it. So questions about anything seizure related?
Thank you for your presentation. It's very informative. So I think the question that I have is about the overlap of sort of physical movement, the manifestations for AHC and seizures. And so, you know, it's just interesting some of the video that you show, even of the girl in the chair. I mean, for those of us whose child have nystagmus or just other kinds of movement, or dystonia from this morning. I mean, it can manifest in AHC episodes, but also in seizures. And I just don't, I wondered if you had any observations on that kind of overlap. And
yeah, so I think you're asking, you know, how do you make confident diagnoses or know what's going on? And this is kind of a theme I've heard, is I'm not sure what my child's doing right now. And I'm not going to have a great answer for you other than I spent quite a bit of my life learning to be a neurologist and treating patients, and I'm come to the conclusion that the more I do it, the less sure I am about what people have, because it's so different. The purest forms of, you know, just the unilateral nystagmus should be pretty clear if you see a lot of it. The purest forms of facial clonic activity is almost always going to be a seizure. But the hemiplegia could be either. That's why there's a very reasonable misdiagnosis adventure for everyone. And you get better and better as you do it. But I defer, you know, the more I do it again, the more variation you see. I think also the more humble one can become, that you don't know what's going on. And that's why I think having additional tools like the EMU is a place to be, to really know with the best possible technology what's going on. If you're an excellent clinical doctor, I think the best neurologists I know are probably 90% right. Pretty good, but you know, I don't want to be wrong 10% of the time. So any tools you can have to get yourself to 100% is going to be the goal. And there's, I would say also, and I think it's evident from my discussion, over-diagnosing epilepsy, misdiagnosing epilepsy, and putting kids on drugs is a bad thing too. You don't want to do that unless you have to put kids on drugs. So you really have to walk the line. And guess what? Providers are scared of seizures too, especially in the ER. And you can easily get started on medications, Keppra, load, because we're scared too. And you try to do something, but you have to be really careful. And once people are on medicine, sometimes it can be hard to take them off of it. So anyway, I hope that answered your question, but it is difficult, and we think we know, but the brain is mysterious, and AHC in particular affects many different systems. And one of my hopes from a research side is to narrow down, if possible, to subtypes of the brain, subcell types, that will help us and think about what those pathways are doing, target drugs to that, and see what is the core and what is variations made out.
My daughter just started like the quiver of the lip like you showed. So are they conscious during that time?
It really depends on how much brain is involved. If it's just like this child just had the face involvement, so that's a relatively discrete part of the brain on the other side that involves face, but real next to it, especially for the left side of the brain, is language. So it doesn't take that much more to affect language areas. It's one of those real estate questions, location, they say. It's really about where the seizures are coming from, what get involved, and most seizures then are going to spread. So the grand mal really means it's spread to everything, including the motor areas. But if something spread and it went just to one area and then stopped, you actually might not even notice it. So there are such things called subclinical seizures, where the EEG tells you have a seizure, but no one would know just looking at someone they're having a seizure. So in your question, though, if it's just a lip, they may or may not, they should be aware because they feel it. But if they have altered mental status again, they may be out of it for a little while, but you can get back pretty quickly.
Yeah, she just explains, like, sometimes when her lips start, she just feels shaky. I can't feel her shaking, but her...
Yeah, and that's going to be, I've seen that plenty of times, that sounds reasonably like a seizure, but when we then put those kids in epilepsy monitoring unit, sometimes it is and sometimes it's not. So,
all right, thank you.
Yeah.
I got two. How do you know when? Well, when my kid has a seizure, usually it's a grand mal right off the bat. Sometimes it slowly starts a little bit and then it progresses, but then it becomes like both sides jerking. Now, one time that happened, and I gave him the 20 milligram diastat pretty quick, like within a few minutes of that real jerking. But later on, like an hour later, you know, I was just letting him lay next to me watching TV, you know, just keeping an eye on him so he didn't throw up and choke. So then once in a while his arm or his leg would flip off of the bed, off of the couch, and then, you know, shake a little, and then I'd just throw it back onto the couch and we'd sit there some more. Then about 2 hours later, it started up again real bad. Mm-hmm. Is that little bit of jerking now and then, you know, showing signs of a continuous seizure, or are they individual events? Like, did that first one ever finish?
Yeah, so that's a great and potentially scary story. First of all, you illustrate really well a focal seizure that then spread to one side of the body, then it became the grand mal. So that's a focal seizure that's secondarily generalized. Just that's how we would think about it. And then your question is really key, and this is why what people in the ER should be doing. Are they still seizing? Are they starting and stopping? So if your child was still seizing in their brain, then occasionally having jerks, which you could then see, that's actually the definition of status epilepticus and is a bad thing. However, it's also possible they could have been starting and stopping and the diastat worked, but then was wearing off and seizure coming back. The question I would ask you also, though, is were you able to communicate in some way with your child? Were they at their baseline?
He was pretty much asleep, out of it.
Yeah.
When I think he's having a true seizure, kind of relating to her question, if I go to give him that diastat, if he fights me and won't let me put it in him, then I figure, yeah, he's got too much awareness.
Yeah.
It's
so
probably not a seizure.
That's one of my pearls too. If child is concerned about what's going in their butt, don't give it. Yeah. But again, the other part is still really critical is your child could have been seizing on and off continuously. So you need to try to wake them up and make sure they can say, yeah, leave me, whatever they're going to do. And if you're not sure, you should probably call 911 in my view, because they can do an EEG in the hospital real quickly and know are they seizing right now or not. So again, it's a judgment call. It's hard to know with everyone. But if you get back to your baseline, very reassuring that you've stopped seizing.
Yeah.
Again, I can only give you general.
I didn't give him another dose of diastat because I figured 40 milligram Valium, that's pushing.
Yeah, but again, how long ago was this?
How long ago did this happen?
Yeah.
Probably 3 years ago.
Okay. I mean, it's a scary story, but I'm glad he got through it. But no one would ever fault you for coming in and getting him checked out for that. But if your kid's back to normal and just sleepy, that's a different scenario. Again, generalizations here, but you have to use your best judgment, and you know your child best.
There's no neurologist in my area.
Yeah, so you're it, right?
Drive out of state. One thing on the VNS, I know of one person who had that VNS, an AHC person, and well, that lead came off, and also that battery pack looked like a pack of cigarettes in the person's pocket. I mean, it was pretty big.
Yeah.
You know, it stuck out. You know, I can express concern because my kid's so skinny that he'd rip it off.
Yeah,
you know,
it's pretty deep in the muscle.
But it's underneath the muscle.
Yeah, it's pretty deep. And then I've only seen a couple cases out of hundreds where they actually had a neck problem. That's pretty unusual. I would just say make sure you use a surgeon who's experienced with this. But usually it's pretty well tolerated. Thank you.